I am Rachel Outerson, Clinical Assistant Professor of Anesthesia at Stanford. This lecture will be on the axillary approach to brachial plexus block, also called the axillary block. In this presentation, I will review the uses of the axillary block, the anatomy of the axilla surrounding the brachial plexus nerves where the block is performed, how that anatomy affects the areas that are and are not anesthetized by the axillary block, how to perform the block using an ultrasound-guided technique, and some of the limitations and potential complications of this block. The axillary block is a nerve block of the terminal nerves of the brachial plexus and is an appropriate block for anesthesia and analgesia for surgeries of the elbow, forearm, wrist, and hand. The area anesthetized by this block is illustrated in the colored patches on the arm in this diagram and is made up of the distributions of several terminal nerves of the brachial plexus. The smaller figure to the right represents bony innervation. The light blue represents the area of cutaneous innervation of the radial nerve. It appears from this anterior perspective to be two separate areas, but they are actually connected by a strip down the posterior aspect of the forearm and the arm. The darker blue represents the area of cutaneous innervation of the median nerve. The red represents the area of cutaneous innervation of the ulnar. Now these three are the terminal nerves of the brachial plexus that we most commonly think about in the axillary block because they are visualized adjacent to the artery during performance of the block. However, also anesthetized are the medial cutaneous of the nerve of the arm in darker green and the medial cutaneous nerve of the forearm in lighter green, which run in close proximity to the neurovascular bundle but are usually not visualized on ultrasound. Also, and very importantly, is the musculocutaneous nerve, represented here by yellow, which is worth noting separately because it often does not run alongside the artery and must be blocked separately to achieve complete anesthesia of the forearm and wrist. One important side note here is that despite the fact that we call this the axillary block, this nerve block does not in fact block the axillary nerve, which is a branch off of the posterior cord which leaves the plexus proximal to the axilla. So let's discuss the anatomy of the axilla. For the purposes of this discussion, we will often refer to structures as proximal or distal, medial or lateral. Lateral in this case refers to the radial or thumb side of the arm, which in this diagram is up as the arm is abducted. We'll also use the terms anterior and posterior. In this diagram, anterior is facing you. Muscular structures. So first we'll note the pectoralis major, which is divided in this diagram to show the structures beneath, so its cut edges are marked with stars. And this is an important landmark because it is just distal to the insertion of the pec major on the humerus that the axillary block is performed. That's right where you're going to place your ultrasound probe. The latissimus dorsi muscle is also an important landmark because it's going to form part of the conjoined or conjoint tendon, which attaches to the humerus, forming the floor of the ultrasound view during the axillary block. You're also going to take note of the biceps brachii, which is just lateral to the neurovascular structures important to this block. And then not well illustrated in this diagram, but important to the block, is the coracobrachialis. You don't see it labeled because it's not visualized here, but it originates just medial to the biceps, and at the level that you're seeing it here, it would be deep to the biceps. It'll be better visualized when we look at the cross-section and ultrasound views. The triceps brachii make up the posterior musculature of the arm, and also shown as the deltoid, which originates from the lateral clavicle endochromion and is seen running along the posterior humerus at the level of this block. Important vasculature include the axillary artery and vein. Now this is only showing one vein running alongside the nerves there, but you'll see when we actually look on ultrasound there's almost always 2 to 3. And now, the nerves. 2 of the 3 cords of the brachial plexus can be visualized here, the medial and the lateral cord. The posterior cord is not seen on this anterior view because it is posterior to the artery. The musculocutaneous nerve is seen leaving the lateral cord to move into the more lateral musculature, where it will pierce the coracobrachialis. The median nerve is shown being formed from two branches, one from the lateral cord and one from the medial cord. The medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm are seen coming off the medial cord, but remaining relatively close to the rest of the neurovascular bundle, which is why they will generally be anesthetized so long as adequate volume is used for the block. The ulnar nerve is what remains of the medial cord after those other branches have left. The radial nerve is seen here too, but only in cross-section and at the most distal aspect, and that's because, like the posterior cord from whence it came, it is posterior to the artery. Lastly, here's the line demarcating the level at which the block will be performed. So, let's take a look at the cross-sectional and ultrasound anatomy at that level. So in these two diagrams, we see on the left a cadaveric cross-section and on the right an ultrasound cross-section, both at the level at which an axillary block is performed. We'll orient ourselves here using medial and lateral, anterior and posterior for both of them. But of note, these two diagrams are not exactly identical. For example, the cadaver section shows the humerus at the lateral edge of the picture, while the ultrasound does not. However, important landmarks and relationships between structures are consistent between the two. So let's start by identifying musculature. On the lateral side, we see the biceps brachii with the coracobrachialis muscle deep to it. Posteromedially, we see the conjoint or conjoined tendon, which is formed by the latissimus dorsi and teres major muscles. Next, we will identify the artery and veins. It is notable that the cadaveric section has 3 veins, while the ultrasound picture shows only 2. Some variety in number and location of veins is to be expected. The 3 nerves found adjacent to the artery are what we're going to look at next: ulnar, median, and radial. The ulnar nerve, here circled in yellow, is generally found anterior to the artery and on the medial side. The median nerve, here circled in orange, is found anterior to the artery and more lateral than the ulnar. The radial nerve, here circled in green, is generally found posterior to the artery. Now let's move outward to the musculocutaneous nerve. It's circled in purple here, found lateral to the neurovascular bundle, and it may be within the coracobrachialis muscle or between the coracobrachialis and the biceps brachii. Of note, it is shown relatively close to the artery in these pictures, but it can be further away. Lastly, the cadaver section has a nerve that we rarely note on ultrasound, the medial cutaneous nerve of the forearm. This demonstrates that though it leaves the medial cord proximal to this point, it remains in close proximity to the other terminal nerves. Now let's talk about how to perform this block. With the patient's arm abducted, the ultrasound is placed just distal to the insertion of the pectoralis major muscle, giving us that same cross-sectional view we were looking at on the last slide. The relevant anatomy is identified, starting with the artery, then working outward to identify the nerves. Make sure to release any significant pressure on the ultrasound to ensure that veins are not compressed and can be visualized. Scan laterally from the artery to visualize the musculocutaneous nerve within the coracobrachialis or biceps, between the biceps and coracobrachialis muscles. Scan proximal along the arm, meaning towards the chest, to watch that nerve travel closer to the plexus and confirm that you have identified the correct structure. Then place your needle using an in-plane technique such that the needle length can be visualized during approach, allowing you to avoid vascular puncture. There are 2 schools of thought as to ideal local anesthetic spread for this block. One is that each nerve, radial, ulnar, and median, should be blocked individually. The other is that circumferential spread around the artery should be the goal. Both of these approaches work. Targeting the nerves may have a higher risk of causing neuropathy. Targeting the artery may have a higher risk of causing vascular puncture and local anesthetic systemic uptake. In either case, the musculocutaneous nerve must be blocked separately, and in either case, about 5 to 7 milliliters of local anesthetic will be used per nerve. Now let's talk about why we would want to perform the axillary block. We have other options for elbow, forearm, and arm surgery. What makes this block better or different from the infraclavicular or supraclavicular approaches to the brachial plexus? For one, it's a convenient block to use in patients with difficult anatomy. Sometimes high BMI, the location of a port, pacemaker, or central line, an infection, burn, scar, or previous radiation can make those more proximal blocks more challenging, difficult to get a good view on ultrasound. Another consideration is for patients in whom phrenic nerve block is of particular concern, for example, a patient with severe COPD. For them, axillary block has the absolute lowest risk of the brachial plexus blocks of causing phrenic nerve paresis. In my own practice, I'm also more likely to use an axillary block than a supraclavicular or infraclavicular block for a patient who's anticoagulated or has coagulopathy, given that the anatomy of the area allows for external compression of bleeding. Limitations of the axillary block are a result of the anatomy of the area. The musculocutaneous nerve has historically been missed in single injection techniques. This limitation, however, comes by the use of ultrasound. The fact that the axillary nerve is not blocked is a limitation that differentiates this block from the supraclavicular or infraclavicular approaches, which do cover the axillary nerve. And the intercostobrachial nerve, which gives cutaneous innervation to the proximal medial arm, is not covered, which is not different from other approaches to the brachial plexus. It must be blocked separately if that distribution is required for surgery or tourniquet anesthesia. Most complications of axillary blocks are not significantly different from other nerve blocks, and they include relatively rare infection, bleeding, nerve injury, and local anesthetic systemic toxicity. But one unique complication is significant injury to the artery, causing dissection, and even in some reports, formation of an arteriovenous fistula. Of note, pneumothorax is not a complication associated with axillary block, unlike other approaches to the brachial plexus. In summary, the axillary block is a simple and effective nerve block for the distal arm. It has a lower rate of some of the side effects and complications that can occur with other approaches to the brachial plexus. Ultrasound guidance allows for safe performance, in which one must be very careful to avoid the vasculature, which is variable between patients. And the musculocutaneous nerve must be found and blocked separately from the others to achieve complete block. We'll finish with a board exam question. A 25-year-old female is scheduled for tendon reconstruction of the second and third fingers. An axillary block is performed with 30 milliliters of 0.5% bupivacaine using a transarterial approach. However, 30 minutes later, the patient still complains of pain when the surgeon pricks the lateral wrist just proximal to the thenar eminence. The most plausible explanation for continued sensitivity is inadequate block in the distribution of A, the median nerve, B, ulnar nerve, C, radial nerve, D, musculocutaneous nerve, or E, medial cutaneous nerve of the forearm. The correct answer is D, the musculocutaneous nerve. The skin around the thenar eminence is a convergence of multiple nerve distributions, radial, median, musculocutaneous. However, the musculocutaneous nerve is the most likely to be missed with the single shot technique described in this question. If they don't specifically mention that it was blocked, it was probably missed. Thank you very much.